This is Blood and Cancer News from MD Edge and Medscape. I'm your host, Nick Andrews. In today's list, robot-assisted partial nephrectomy and bevacizumab for hereditary hemorrhagic telangiectasia. Remember, each of these stories has a link in the show notes to the original story on MD Edge and Medscape. We begin today with death rate data for COVID-19 patients who have cancer. Patients with cancer who are hospitalized should be treated in COVID-free zones because those patients have a high risk of acquiring nosocomial COVID-19 that comes with an increased risk of mortality. This is according to a presentation at the 2020 virtual meeting of the AACR. The presenters cited an observational study of patients with COVID-19 and cancer. The researchers of that study found that 19% of patients had COVID-19 that was acquired during a non-COVID-19 related hospital stay, and 81% had community-acquired COVID. At a median follow-up of 23 days, the overall mortality rate was 28%. However, the all-cause mortality rate in patients with nosocomial COVID-19 was more than double that of patients with community-acquired COVID-19 at 47% and 23% respectively. The study included 250 adults and 3 children with COVID-19 and cancer who were identified between March and June of this year. All patients had either laboratory-confirmed or presumed COVID-19 and invasive cancer. The most common cancer types were similar to those seen in the general population. Lung and breast cancer were the most common, followed by lymphoma, prostate cancer, and colorectal cancer. Most patients were on active anti-cancer therapy, most often chemotherapy. 236 patients were in Quebec and 17 patients were in British Columbia in the western part of the country. At the time of the study, Quebec was very highly impacted by coronavirus outbreaks. In the study, researchers report that the median overall survival was 27 days in the nosocomial group and 71 days in the community-acquired group. A multivariate analysis showed that nosocomial infection was strongly and independently associated with death, and that other risk factors for poor prognosis included age, poor performance status, and advanced stage of cancer. So, how can we apply these findings to practice? Well, the findings reinforce the importance of adherence to stringent infection control, according to Dr. Ariel Elkrief, who is an oncologist and a researcher at the University of Montreal. Dr. Elkrief reported the results of this study and commented on them at the AACR virtual meeting. She said that in ambulatory settings, clinicians need to continue efforts to decrease in-person visits through increased use of telemedicine. For those who need to be seen in person, screening for symptoms or the use of polymerase chain reaction testing should be used when they're available. And our second story today, robotic renal surgery beats open partial nephrectomy. Indeed, complications were less common with robots-assisted partial nephrectomy than with open partial nephrectomy. This is according to the results of a large study of patients who had renal cancer that was reported at the Virtual Congress of the European Association of Urology. The IRON study, as it was named, was conducted by Dr. Alessandro Lacker of the San Raffaele Hospital and Urological Research Institute in Milan, Italy. He presented the data virtually at the meeting. Dr. Larger reported that he and his colleagues found that the robot-assisted surgery was associated with a 61% decrease in intraoperative complications and a 71% decrease in overall complications. The study was performed at 9 high-volume centers, and it included about 3,500 patients who had renal cancer. Patients were recruited if they had a localized renal cell mass with no nodal involvement or METs. In total, slightly more than 2,400 patients underwent the robot-assisted procedure, while about 1,060 patients underwent the open procedure. Intraoperative complications occurred in 5.7% of patients who underwent the robot procedure and in 9.3% of patients who underwent the open procedure. Okay, so let's look into specific complications. First, blood loss and hemorrhagic complications. Patients who underwent the robot-assisted surgery had less median blood loss at 150 milliliters compared with 180 milliliters for those who underwent the open surgery. Patients who underwent robot-assisted surgery also experienced lower rates of hemorrhagic complications at 6.4% compared with 9%, respectively. The operative time was longer for the robot-assisted surgery at a median of 150 minutes compared with 120 minutes for open surgery. However, patients remained in the hospital for less time with the robot surgery than with the open procedure at a median of 4 days and 6 days. The robot surgery was associated with fewer surgical complications than open surgery according to the Clavia and Dindo system. Grade 2 or higher complications occurred in 12% of robot patients and 20% of open patients. Grade 3 or higher complications occurred in 4 and 6% respectively. Early renal function was better for patients in the open group. However, there was no significant difference between the two cohorts at 1-year follow-up. Dr. Ben Calicombe is a consultant urological surgeon at Guy's Hospital and St. Thomas's Hospital in London, who chaired the poster session at which this study was presented. Dr. Calicombe said that this is the kind of study that just needs to be done. He specializes in treatment of kidney and prostate disease using robotic surgery. He pointed out that about 75% of procedures in the UK presently are being performed with robotic assistance. Dr. Calicombe also said that what the data are telling us is that those who are really confident in robotic surgeries can achieve even better outcomes in very complex cases. He said that he thinks it's not any longer dependent on the tumor factors. The answer to the question is only determined by human factors. And we'll wrap up today with a large cohort study on bevacizumab for severe hereditary hemorrhagic telangiectasia. An international study presented at the 2020 virtual meeting of the International Society on Thrombosis and Hemostasis reports that systemic bevacizumab is safe and also highly effective for the management of HHT. HHT is also known as Osler-Weber-Rendow disease and is a rare genetic progressive multisystem bleeding disorder resulting from disorder of angiogenesis. Hemoglobin levels increased by 3.2 grams per deciliter, and epistaxis severity scores decreased by a mean of 3.4 points in 238 patients from 12 centers who were treated with bevacizumab for a median of 12 months. The researchers further reported that the median number of red blood cell units transfused during the first year of treatment decreased by 82%. This is compared with the 6 months prior to treatment. The median iron infusions decreased by 70% during the same period at 8 versus 2. Dr. Hani Al-Samkari is a researcher and a hematologist at Mass Gen in Boston. He said in the presentation that the improvements observed occurred within the first 6 months of treatment and were maintained through 12 months. The participants in the study had an average age of 63 and were treated with systemic bevacizumab between 2011 and 2019 for the primary indication of moderate to severe chronic HHT-related bleeding and anemia. In the study, treatment involved 4 to 8 induction infusions followed by bevacizumab maintenance, either as continuous or scheduled maintenance at 4, 8, or 12-week intervals regardless of symptoms or as needed. Patients received a median of 11 infusions and 181 received maintenance treatment, including continuous or scheduled maintenance in 136 patients and as-needed maintenance in 45 patients. The treatment was generally well tolerated. The most common adverse events during the 344 patient years of treatment were hypertension, fatigue, and proteinuria. No fatal treatment-related adverse events occurred, and no increase in adverse events occurred with longer treatment. Subgroup analyses showed that outcomes were similar regardless of underlying pathogenic mutation, but among those receiving bevacizumab maintenance, the continuous approach compared with the as-needed maintenance was associated with greater improvement in hemoglobin and ESS during months 7 through 12 of treatment. Though rare, HHT is the second most common bleeding disorder globally. Dr. Al-Samkari said that despite this fact, HHT has 0 FDA-approved therapies. He went on to say that the current mainstay of care is surgical or procedural local hemostatic intervention, which is usually temporizing and hematological support in the form of blood and iron. However, given that the underlying genetic defects that cause HHT result in elevations in VEGF, targeting VEGF with existing anti-angiogenic agents is a promising approach. In fact, several centers have been using bevacizumab for several years as an off-label treatment for bleeding in this setting. And while scattered case reports and small case series suggest efficacy, no large or definitive studies have been conducted, and safety has not been carefully evaluated. And that's it for the 5th edition of Run the List. Blood and Cancer is produced by MD Edge editor Jennifer Miller and MD Edge editor Mark Lesney. All MD Edge podcasts are produced by MD Edge executive editor Kathy Skarbeck and Medscape editorial vice president Dr. Ivan Aransky. You can find the links to every story in the list by clicking in the show notes. I am the voice of Blood and Cancer, Nick Andrews.